and then we will start with the questions and
Thank
one by
you,
one we
Dr.
can see.
Hudda. Thank you. I am actually an epidemiologist, so I just deal with numbers at the population level. So, and a clinician sees the cancer patients. So that perspective is different. And when we see the population level, we have to weigh the risk benefit, we have to weigh the burden. And I will just present some figures ki what happened at the population level over the past 3 decades, how the cervical cancer trend came down. Actually, what we are hearing is that cervical cancer, India has the largest and all that. India will have the largest because we have a large population. But if you see the relative past 3 decades, the precipitous fall in cervical cancer incidence, and I will just share some figures which should help making the policy decision. At public health decisions are different, clinical decisions are different. So I will just share the slide. I think I have a option of sharing the screen.
Yes.
Is it visible? Okay.
Yeah, it is there.
Let me get the. Can you? Yeah. This is the. Yeah. This is the. This would be the strong. What are the risk factors and incidents and trends? We know the risk factors well, and what is the role of HPV, and what are the precancerous lesions and their course? Because up till now, all the trials have been only measuring the surrogate outcomes. There have not been trials long enough to measure the actual outcome, that is cervical cancer. So, for that, we should know the natural history of the intermediate lesions, that is CIN1, CIN2. Then, evidence of HPV vaccines. What is the present evidence? The evidence, what are the gaps in evidence? And because when we are thinking of rolling it out on a large scale level in the universal immunization program, we should be very sure of the evidence, because if we give the immunization mass rollout, we won't have a control group to actually weigh the evidence later also. So we should have a cohort first. We should have a good data, good evidence before taking a big decision. Like, and what are the competing mother and child health problems? And what should be
Dr.
the recommendation?
Banerjee, your slides are not moving. Could you please put it
Yeah.
on slideshow or maybe reshare the
Is it
screen?
moving now? I have changed the slide.
No, it isn't. Could you please reshare the screen? Now it is changing, though it is not on slideshow mode, but the slides are changing now.
Yeah, is okay now?
We are on risk factors for cervical cancer right now. That's the slide, the third one.
Uh,
That's what we
uh,
can see.
yeah. Now is it okay now? I have
Yes.
changed it. So these are the basic figures we should important for policymakers. That what is the incidence? New cases is 14 per lakh, and the deaths is 9 per lakh as on today in India. 9 per lakh women, and decline is more than 21%, and decline on incidence is 21%, and decline in mortality is 32% in 3 decades. That is from 1990 to 2019. So this is important to know. The incidence is as on today is 14.7 per lakh women, and death is 9 per lakh women, 9.2. And there has been a decline in incidence from 21%, and decline in mortality 32% in the last 3 decades. This is before the rollout of the HPV vaccine. So we are already seeing a sharp decline. This may be due to the overall control of the risk factors like multiple sex partners, genital hygiene, less number of children, safe sex because of the HIV and other things. People are becoming more aware. So this is the reference I have given. This is an article in BMC Cancer. So I have given the reference. And just to compare, like we are worried about a woman. In India, the maternal mortality rate is 97 per 1 lakh childbirths. That is almost 10 times than the deaths from cervical cancer. 10 times mothers die, they do not reach the age of having cervical cancer. So, if you see in public health, we have a competing priorities. We are neglecting our mother health, antenatal care is not there, natal care is not there, remote areas, gynecologists are not there, they are not giving the maternal care as well as screening for cervical cancer. Because even after if you roll out the HPV vaccine, you will still require the screening for cervical cancer. For that, you require gynecologists, pathologists at the remote areas. So we have got 10 times higher priority for preventing the maternal deaths than rolling out a vaccine which will work after 20 years, which is not when there are a lot of gaps in evidence. Is the slide changed?
Yeah, it is changing.
So these are some of the gaps. What is the risk factor of human papilloma virus? A risk factor. There are more than 150 strains, almost 200 strains of HPV. As on now, we know it is 16 and 18, which are the high risk, and the vaccine includes this. So majority of HPV infections are asymptomatic and resolve spontaneously. So prevalence of HPV varies from 2 to 42%. This is also important because the high risk of HPV, as brought out by earlier speakers, is the multiple sex partner sexual experimentation. That's why they recommended 9 to 13 years of age. That is for the Western cultures. And most of our Indian culture, I don't know. We should do studies ki how many are having multiple sex partners from their teenage years. Many of our women may not have a first sexual encounter at the 25 years of age, and then they say HPV vaccine doesn't work after 25 years. So these are some of the issues. Then the higher prevalence of 42% is the commercial sex workers, people with AIDS and HIV. So if we want to test the vaccine fast, we should test it out in the high risk group first rather than going for the general population. I am nothing against the vaccine, but we have to be very sure whether the attributable risk reduction is there or not, in particularly people with low risk Indian culture. So we can try it out among commercial sex workers or people with HIV AIDS before rolling out. Then high prevalence found in patients with cancer, women living with AIDS. But again, there is a paradox because the commercial sex workers may again be in the age bracket 25, 30 years. But again, we don't know whether giving it 9 to 13 years will prevent in the long run. So these are some of the issues. So these are some of the natural history of this early lesions. Precancerous lesions are cervical, intraepithelial, neoplasia 1 and neoplasia 2, CIN1 and CIN2. Majority revert back. After some time, they revert back to they clear by themselves and they do not progress to. So we and most of the trials they have measured this CIN1 and CIN2 as clearance, which is again gap in the strong evidence because they would have cleared by themselves even without the HPV vaccine. And there are hardly any studies to test the final outcome. We are using the intermediate outcomes. So this is one gap. So because of that, this is the limitations in evidence. We do not know how well HPV vaccination will protect against cervical cancer. Trials have not focused on the outcome, final outcome. They have too few participants and did not follow them for long enough. Cervical cancer may take decades to develop. And you see, most of the people will go who may not be at high risk. They are well educated, they are having safe sex, they are not having multiple partners. And another thing I am worried is the HPV vaccine is promoted with so much of propaganda that people will not go for cervical cancer screening. Even the vaccine manufacturers say even after you have the vaccine, you cannot do away with cervical cancer screening. And there have been some studies which say that if the cervical cancer screening is in place, the extra protection is not given by the HPV vaccine because we still don't know whether there will maybe strain replacement. And I was reading just last week a very interesting news article in Chennai, I think. In Chennai, many screening centers for cervical screening refuse cervical cancer screening to single mothers, or not single mothers, single women. They refuse cervical cancer screening to single women, saying that it is only for married women. So this is very strange. A single woman is not having access to cervical cancer screening in many centers in Madras, whereas the vaccine is being promoted up to 9 to 13 years in teenage girls. So there is some contradiction here. Because what I am saying is the public perception would be that this is a magic bullet. that now I have gotten the HPV vaccine, I can indulge in any type of behavior. I do not have to go for cervical screening. So these are the cultural, social factors which I have to keep in mind, which can be the side effect of high pressure promotion of the vaccine, which we don't know the long-term efficacy. I am not talking of side effects at all, but even for efficacy, even for the budget, we have to be very certain, because once you roll it out on a mass level, you cannot take it back. And as it is, we have seen for the past 3 decades, the incidence is falling, the deaths are falling from cervical cancer, and everything would be attributed to vaccine, but it has already come down. If you see then published numbers of randomized trials may overstate the efficacy. As I said, testing occurred too frequently in the trials and then in real world setting, which may show that most of the lesions are regressing, which they regress in any case. CIN1 and CIN2. Trials use composite surrogate outcomes, some of which, such as HPV infection, and even HPV infection cannot be a long-term predictor of cervical cancer until we have completed the trials. Subgroups were overanalyzed. So there were a lot of, there is a paper, I will be citing the paper. If you read that paper, it is in the Journal of Royal Society of Medicine, that brings out the gaps in the literature. The trial population have limited relevance and validity for real world setting, because most of the trials were done in women. No trials have been done in teenage, 9 to 13 years. They tried it about 10 years back in Gujarat and Andhra Pradesh. There were certain adverse events, there were death of certain tribal children. So after that, no trial in teenage has been done, and we are trying to roll it out on a mass scale among teenagers. We don't know who will monitor the adverse effects. I mean, we have to see in public health, we have to see the logistics. Trial women are older, and the target population we are aiming is the younger girls. We do not have enough data on the benefits of women who may not have been exposed to HPV before they were. So there are a lot of question marks. There are a lot of gaps. Surrogate outcomes I have already discussed will not eliminate screening. This is important, because when you are planning a policy, how it will change the practice, it is not going to change the public health practice, and it is not going to give any extra advantage in prevention of mortality from cervical cancer if you have a good screening program in place. And as I said, last 3 decades, the cancer deaths have come down drastically. Long-term efficacy and side effects are not known. There are some evidence in girls of before sexual activity, but they are not very large sample size. Ongoing observational studies may tell us about the long-term effects on rates of survival, but it will take many years before we have evidence. That's why we do not roll it out at a mass level. We can give it in the market, whoever wants to take it. And as I said, if you want to launch trials, it can be done in the high-risk groups, high-risk societies, and then followed up rather than in the general population, because we will lose the control group. Then, as I said, there have been some past mishaps. HPV vaccine trials among adolescent tribal girls undertaken in low-key manner in India, 2009. Gates Foundation conducted trials. Again, there was an unethical violation. It was described as an observational study, whereas it was an intervention studies, and there was death, and it was investigated the deaths there. There was a public outcry that was investigated by a parliamentary committee, and the committee indicted the Gates Foundation and ICMR for irregularities in unethical trials and recommended a detailed investigation. More than 10 years, no investigation has been done. So these things should be cleared before rolling out on a still larger scale, because as it is, we do not have the adverse events reporting system in our country. We do not have the health services in the remote areas which will report the adverse event monitoring and all. This should be put in place before we are thinking of a large scale. My idea is whether to put it in the national program. As on today, it would be too premature. So this is the way forward. Should first monitor further, as it is the incidence has fallen down last 3 decades. So we should monitor further whether the other measures are bringing down the safe sex and protection and other genital hygiene. And HPV subtype prevalence, we should require more studies, because we may find that other strains are coming up due to vaccine pressure. 1618 is now, you have a vaccine for 1618. After some years, it may be the other strains which may come up. So we have to do that research first. Ensure cancer surveillance and registration are in place before mass rollout. national long-term efficacy and effectiveness studies should be there, and most important, adverse events reporting system should be in place. So these are some of the references. This is the first one is very important, which gives in very clear terms what are the gaps in evidence, with being totally neutral. What are the gaps in evidence? And this is one which I had just written an article for the general public, which has got all the links to number of references regarding the different gaps in literature regarding the adverse events. So that not to clutter the PowerPoint, I have just given one reference and other links are there in that. So I think that's all. Thank you.
Thank you. Thank you so much, Dr. Amitabh. A couple of questions that I wanted to ask you. If the immune system is compromised, would the vaccine still work?
Immune system.
Yeah, if it's a compromised immune system, should we go ahead and give the vaccine?
We don't know, madam. I mean, even if the immune system is not compromised, as I said, we are making the measurements in the interim outcome measures, like the interim lesions. I mean, we are not having the. So, and you are very right that we don't know. Like I suggested, we can try the vaccine in the HIV patients, but again, that's the important point there. If they have got an immune deficiency, whether vaccine will go, and we may get spurious results once again. So that's a good question. I think that's yeah. So there are many
Yeah,
gaps.
so
It's not so.
basically, does it help us to trigger immune response, make antibodies? What is
Yeah,
the
it is. That is the measure they have done. That is the that's why it says they have measured the antibodies and they have measured the initial lesions.
I'll come to you, Dr. Sujata.
Yeah.
Does the vaccination, so I think that's answered. I wanted to ask you the healthy immune system, I wanted to ask that question. We'll ask this to Dr. Sujata. I know you are very eager to speak on this. And of course, we come to your presentation now, Dr. Sujata.